this, we're taking 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 with a pinch of salt.
Hello, ladies and gentlemen, and welcome to another episode of A Pinch of Salt, the ERA podcast where we try to ask important clinically relevant questions to provide you, our dear audience, with clinically relevant answers. My name is Andrej Kobernet. I'm a nephrologist from Slovenia, and this is the episode on C3 glomerulopathy, a complement-mediated disease, so you can expect to hear about the differences between C3G and atypical HUS, differences between C3G and immune complex glomerulonephritis, how do we assess complement activation, how do we approach therapy, and much more. With us to discuss all of this is Marina Vivarelli, a pediatric nephrologist with extensive clinical and research experience in this field. Dr. Vivarelli is the chief of the Laboratory of Nephrology and chief of the Clinical Trial Center at the Bambino Gesù Children's Hospital in lovely, incomparable Rome, Italy, La Città Eterna. Marina, welcome to A Pinch of Salt.
Thank you, Andrej. It's a pleasure to be here with you all.
Well, thank you for trying to demystify this difficult disease, I would say. It's rare, and many of us don't have a lot of experience in it, which makes it always difficult to treat. So my first question would be C3 glomerulopathy and atypical HUS are prototypical diseases in which complement activation is the primary disease mechanism. So what's the difference in the pathophysiology of these two diseases? Why do some patients with complement aberrations have C3G and then some others get HUS, atypical HUS?
Okay, so that's a great question, and it's a question to which we only partly have an answer right now. So C3 glomerulopathy and atypical HUS are prototypical diseases in which there's a dysregulation mainly of the alternative pathway of complement. And in HUS and atypical HUS, you get this affecting mainly the terminal pathway of complement, and it affects it in providing damage at an endothelial cell level. So when you're thinking about complement dysregulation in these two diseases, the main difference that is always important to keep in mind is that in atypical HUS, the dysregulation is happening in terms of pathophysiology, in terms of determining damage to the kidney at the endothelial cell level. Instead, when you're thinking about C3 glomerulopathy, it's happening in the circulation. And then as a result of what's happening in the circulation, you're getting accumulation of C3 deposition in the glomeruli, in the glomerular filtration barrier. So one is a systemic disease, C3 glomerulopathy. In fact, you can have this deposition even in the retina. It's called drusen. And instead, in atypical HUS, you're having it at the endothelial level, mainly in the kidney, but it can even be the endothelium of many other organs and apparatuses, mainly, as we all know, the central nervous system. So that's the big difference. Intriguingly, the genetic mutations are affecting the same genes. There are some differences because, for example, in atypical HUS, the mutations tend to be more frequently heterozygous, and it's much more frequent to have a mutation in atypical HUS compared to C3G, where mutations are found in a smaller percentage of patients, around 20 to 25% in some groups, sometimes even less, whereas for atypical HUS, we're up to 65, 70% of patients. And we know that in C3G, there are these nephritic factors that determine the dysregulation, so it's quite different. We also know that in addition to the homozygous-heterozygous difference, there are also differences in the location within that gene of the mutations between atypical HUS and C3G. However, sometimes it's the exact same mutation, and you can have a family with the exact same mutation in which one individual develops atypical HUS and the other one develops C3G. And you can even have the same patient developing one or the other at different time points in his lifetime. So the the truth of the matter is these are diseases in which the genetic component is definitely one of the drivers, but it's not a monogenic condition. So the pathogenic variant is a susceptibility to the disease, and then there are other players. So it's much more complex. So I can't give a simple answer, and I hope I haven't been more confusing than simplifying, but it definitely is true, and it's important to keep in mind that looking for these mutations is more than anything else important for atypical HUS to give us an idea of prognosis, and for C3 glomerulopathy to give us an idea of the fact that we've made a correct diagnosis of a disease that can be pretty tricky to diagnose with certainty, especially when you have the forms that have an immunofluorescence in which the C3 is not the only thing you see.
Which is a perfect segue to the next question. Exactly, because the next thing I wanted to ask, so C3 glomerulopathy is a diagnosis that is made by doing the kidney biopsy and finding almost exclusively C3G, but you often find in membranoproliferative glomerulonephritis also some immunoglobulins, but the C3 is much more pronounced. So what you've explained now is that there's actually probably a continuum between C3G and atypical HUS. What I'm wondering is there a continuum between C3G and immune complex glomerulonephritis? And is there then a role for anti-complement therapy in immune complex glomerulonephritis? Are these two also very related? Because immune complex glomerulonephritis also is not easily treated many times. And how important is electron microscopy perhaps in the diagnostic workup of these patients? So it's quite a loaded question, but I'm really interested in it.
Okay, so I'll do my best once again to answer you. And it's a very good question, and a question that also, once again, we're still struggling to respond to fully. So first of all, I like very much the fact that you spoke about immune complex GN and not immune complex MPGN. This is one of the things that we really try to drive home when we're talking about this disease spectrum, because historically, all of these diseases were called MPGN, and there was type 1, type 2, type 3, and we knew that type 2 was called dense deposit disease, and there was a dysregulation of the alternative pathway of complement. And now we've been discovering that the alternative pathway of complement is involved in many of these different forms. But the bottom line is they're not all membranoproliferative. It depends at what time point in the history of the patient's disease you do the biopsy. So that's very important. So you definitely need to have proliferation, but you don't need to necessarily have a membranoproliferative pattern. You can have mesangial etc. So this is the first concept. In terms of the relation between IC-GN and C3G, so the fact that some forms may have a vastly predominant C3 deposition by immunofluorescence in the glomeruli, but in some forms, even of DDD, you have a coexistence of perhaps even equal intensity of IgG, IgA, and IgM, or even C1q to make things a little bit more complicated. So going towards a full house immunofluorescence. So this is actually true. And if you look at the old papers describing DDD, it was actually found even in the olden times. So it's something that we're just reconfirming now. And this obviously makes the differential diagnosis particularly important to perform in a very stringent manner. So when we have the exclusive or the predominant C3 by immunofluorescence, it's easier to know that this is the family of diseases that we're looking at. Probably we have even low serum C3 in the circulation, which helps us even more, and everything is a little bit more simple. If we have an immunofluorescence that is more of a full house pattern, or anyhow quite a similar intensity of IgG and C3, then we have to be careful, first of all, especially in adults, to exclude secondary forms. So to exclude vasculitis, to exclude infectious causes, and to exclude monoclonal gammopathies, especially if your patient is over the age of 50. However, once you have excluded these, you should consider that the underlying pathophysiology may be secondary secondary to dysregulation of the alternative pathway of complement. And in the scientific articles in which this has been done carefully, in reality, the frequency of having genetic pathogenic variants in these genes, or of having circulating nephritic factors or anti-factor H antibodies, so something that really proves that there is this dysregulation, is absolutely identical between the ICGN forms and the C3G. So in those cases, if we've done our homework carefully at the beginning of the differential diagnosis and excluded all the secondary forms, we can feel confident that we are in this disease spectrum. And to answer the second part of your question, since we are within this disease spectrum, it makes sense that proximal complement inhibition would be equally effective in both of these forms. And this is also reflected in the way that the trials have been run and in the fact that the new complement inhibitors that are coming through the pipeline are assessing both of these diseases as if they were two facets of the same spectrum, which is what we feel more strongly is the case. Another important consideration is that the ICGN manifestation of this disease spectrum, if we want to call it in this way, is probably more frequent in children, where you have an infectious trigger activating the classical pathway in addition to the underlying dysregulation of the alternative pathway. And therefore, you have the classical pathway trademark of the IG deposition as you have an acute post-infectious GN, and perhaps also some IgA, some IgM, or some C1q. So especially if you see the IgG and the C3, if you have an infectious trigger and perhaps you have a lot of humps, the important differential diagnosis becomes with post-infectious GN. And there, it's really time that will tell, because obviously the acute forms will resolve within 8 to 12 weeks with a complete normalization of circulating C3, and you won't have any recurrence. If instead you keep on having disease manifestations, then you know that you have a disease that falls within this spectrum. So I think this is important. And I hope this is helpful. In terms of electron microscopy, oh, good. In terms of electron microscopy, so that's a little bit trickier. So definitely it's helpful if we see the dense deposits. So if we have a C3G, we see the dense deposits, we know that it's dense deposit disease, and that helps a lot. It can be helpful even if we see the classic deposits in many other different locations. In the cases in which we have a ton of humps, which can happen, then there it's a little bit trickier, because a renal pathologist trained up to 15 or 20 years ago, that was pathognomonic of acute post-infectious. So sometimes, especially if you have the coexistence of C3 and IgG by immunofluorescence, and then you have a ton of humps, it's very difficult to say if the patient has acute post-infectious or if he or she has a C3 glomerulopathy. But there, time will tell, because an acute condition will resolve within 8 to 12 weeks and the other one will not. So in the end, in that case, and it's a pretty specific case, but it still is present, especially in pediatrics, you end up having a biopsy where actually the diagnosis is then made more by the clinic than by the clinical phenotype than not by the actual kidney biopsy. For all other cases, and in general, anyhow, it's essential to perform a kidney biopsy here, and it still is essential to perform it when you have these forms. It's just that when you have this picture, you need to put it together with the clinical manifestations, as sometimes happens.
That's great. That's great. I think you explained it beautifully. I just wanted to make a short digression. You mentioned monoclonal antibodies, monoclonal gammopathy, and I'm struggling with this myself as well. So traditionally, monoclonal gammopathy of renal significance is diagnosed when you have monoclonal, or to be more precise, monotypical antibodies in the kidney, and then you assume it's a monoclonal gammopathy. Perhaps you have it in the blood as well, sometimes not. But in the cases of complement activation, it's quite often that you don't have a deposition of a monotypical IgG1. You just have the monoclonal gammopathy in the blood. You get the monoclonal antibody in the blood. Now, of course, this is also pretty common with older age. So how do you know that this monoclonal antibody is actually the thing that is activating the complement? And how do you treat these patients? If you would know that the monoclonal antibody is the thing that is causing the disease, then you would probably treat them with anticlonal therapy like you would in multiple myeloma, but you don't really have a test to prove that, right?
Okay, so for this, full disclosure, you're not asking the right person because I'm a pediatric nephrologist. So I have
Sorry.
never cared for a patient. No. I've never cared for a patient with a monoclonal gammopathy related form. What I do know just from the literature and from my experience is that the diagnosis can be tricky. It can be tricky to identify the monoclonal clone, and it can be present only in the circulation, as you were saying. And I think mostly it is considered that the sort of first line treatment should be treatment of the underlying dysregulation of the clone. However, there is some evidence that complement inhibition may also be effective, even though in the trials that have been performed up to now, that has always been an exclusion criteria, which makes sense because obviously as we progress with new therapeutic agents that get investigated, obviously you want your cohort to be as homogeneous as possible, and these are patients that are quite different. So essentially time will tell. For the moment, I would say that the first line treatment would still be a treatment targeting the clone, but I don't think that we can rule out that will be a space for complement inhibition even in this realm, even though, again, you're not asking the right person because I've never actually treated anyone with this condition.
Sorry, I just got so excited. I just went straight for it. Right. Okay. So next question is that, okay, we as nephrologists are used to assessing the activity of disease by assessing kidney function, the amount of proteinuria, and so on and so forth. But with a disease that is because of complement activation, we also think about assessing complement activity. But the problem is that these tests that we usually use, C3, C4, C5b9 in the serum, or CH50, are notoriously unreliable in terms of telling you whether the complement is activated or involved in disease or not. So what's, in your opinion, the best way to assess complement activation? Or is that actually not important and you just assess the effectiveness of therapy by classical nephrological criteria?
Okay, so this is a question that is difficult, and it sort of depends even at what level you're working up your patient. So in general, I would say that the only test, if I were working just on trying to be super practical, the only test that is really useful is circulating C3. So serum circulating C3, if it's low, it's part of the spectrum, especially if the C4 is normal. It gives an idea that you're in the right group of disease. If it remains low, beyond the age of 12 weeks, it's definitely not due to acute post-infectious. And once you know that you have a diagnosis of this type, which needs to be obviously performed by kidney biopsy, you can use the low serum C3 as an indicator of disease activity. And so one of the exciting things for us who have been in the field for many years is that the new proximal complement inhibitors tend to normalize circulating C3, giving you the impression that you're really acting at the heart of the condition. And sometimes you see that in patients who go in remission, nephrological clinical remission, so with normalization of proteinuria, some of those will normalize their circulating C3 and some of those will not. And obviously, if you see that the circulating C3 has not normalized, you worry that their underlying disease is actually still going. Other than that, all the other tests that you can use can be influenced by so many other different things that they are clinically not relevant. Obviously, if you're talking instead at a research level, in highly specialized labs and with a blood sample that is collected appropriately, because the complement breakdown products are very fragile, it can be useful to try to fingerprint more carefully, and it will be important to do this pre and post different types of complement inhibitors to help us understand and phenotype our patients more in detail. But we're not there yet. And when I'm talking to colleagues, I just advise to check the circulating C3, and it is helpful to give you an idea of what's cooking if it is low at baseline.
Okay, that's great. Thank you. So we've come to the possibly most important part, which is therapy. So in this day and age, 2025, for the digital archaeologists that might find this file hundreds of years from now, how do we treat C3G?
So that's a difficult question. We don't have a lot of high quality evidence, but we're probably going to start acquiring some in the very near future. We know that some of the trials have been completed and that they have reported positive results. So the future is looking bright for these patients, and it's important for us to tell them. Up to, up to now, what we have tells us that appropriate management in terms of conservative treatment is super, super important, as it always is. But there is a lot of evidence that RAS blockade and moderating sodium intake and diet have a big benefit in these patients. And obviously, this should be one of the first things that we do together with statins when indicated, or SGLT2 inhibitors. And that's a given. And other than that, in a patient who has a kidney biopsy with a lot of inflammatory modifications, using a short course, of glucocorticoids and associating probably mostly with mycophenolate mofetil has been seen to be effective. It seems to be probably a little bit less effective in adults. In children, we actually see a therapeutic effectiveness of this approach in a pretty vast majority of these patients. But we do worry about the fact that we're still not moving anything of the underlying pathophysiology. And so obviously, the idea of being able to use complement inhibition is very important if you understand clearly that this is the primum movens of the disease. Terminal complement inhibition, so blocking C5 or blocking a C5a receptor, has been attempted. In terms of the use of eculizumab or ravulizumab or their biosimilars, what we know is that about 30% of the patients will respond. If they respond in pretty rapidly, and in a couple of months, you should see a substantial improvement in terms of proteinuria. So if you don't see a substantial improvement, you should probably think that this therapeutic approach is not the correct one for your patient. In terms of the C5a receptor blockade with avacopan, the trial that was performed was a phase 2 trial. It did not reach its primary endpoint, which was a very ambitious primary endpoint in terms of improvement of histological improvement. But many of the patients did show an improvement in proteinuria. So there may be space for this type of approach as well. But obviously, since we know that the underlying dysregulation lies in the alternative pathway, it becomes appealing to be able to act at a proximal level. And we know, luckily, now that we have various different attempts and various different drugs coming through the pipeline, but two agents that have completed phase 3 and that have reached their primary endpoint in a positive, successful fashion. And these are iptacopan, an oral agent that blocks factor B, and pegcetacoplan, which is instead an agent that blocks both C3 and C3b, and which is not oral, but it is administered subcutaneously twice a week. Both of these seem very, very promising, both for C3G and for IC-MPGN in terms of pegcetacoplan, because the trial there was designed to immediately address both of these diseases. Whereas for iptacopan, we know that it looks very good for C3 glomerulopathy, but the trial for IC-MPGN, as they called it, or ICGN, as you correctly called it, is still ongoing, and we don't have any results. But I think that in the future, it's most likely that both of these agents will be available, hopefully rapidly approved, and that we will be able to use them and gain understanding of their true efficacy in real world.
Yeah, that's great. That's beautiful. Of course, C5 inhibition might not work completely because we tend to think about the complement pathway coming to its end, to the terminal attack complex C5b9, but that's not necessary for the complement to do damage. With C3a already attracts leukocytes and all that. So
Exactly.
You don't need
And
that
it's
final point. Yeah.
exactly. And while in atypical HUS, going back to what we were saying at the beginning, it is the membrane attack complex damaging the endothelium, and we know that very clearly. And the results of C5 inhibition are absolutely spectacular. Instead, in C3G, it's more the fact of the C3 being continually produced and deposited in the glomeruli. And so, by blocking the membrane attack complex, you do have some anti-inflammatory benefit, and this is visible in some patients, but you're not really doing anything to the underlying deposit of C3. So the kidney biopsy is probably not going to change much. You don't normalize your serum C3 if you had it low at the beginning. And so you're not really acting at the heart of the condition.
Exactly. Beautiful, beautiful. So just one more related question remains
Okay.
for today, and that is a number of patients with different disease phenotypes, so either C3G or ICGN or even IgA nephropathy, have anti-factor H antibodies. Now, does the presence of these antibodies influence your approach to therapy? Because we're used to treating antibody-mediated disease by giving cyclophosphamide, rituximab, mycophenolate mofetil, perhaps. Does that influence how you treat the patient when you do get anti-factor H antibodies?
Okay, so that's another good question. So, in addition to the diseases that you mentioned, anti-factor H antibodies can also be present, particularly in the Indian continent, in atypical HUS. And there it has been shown very clearly that this is a form of atypical HUS, which is very aggressive. It has a high risk of relapse. And there is a clear clinical correlation between the levels of the anti-factor H antibodies and the risk of relapse. And there is evidence that using bread and butter immunosuppression, whether with cyclophosphamide, glucocorticoids, rituximab, plasmapheresis in the acute phase and mycophenolate in the maintenance phase, and pulling down those levels has a therapeutic efficacy in reducing risk of relapse. It is also shown very clearly that if you have very low anti-factor H antibodies, your risk of relapse is also going to be very low. The situation for glomerular conditions is much less clear cut. The levels tend to be much less high. And to the best of my knowledge, there isn't any real evidence that modulating them with, for example, rituximab, so an anti-CD20 monoclonal antibody, is effective. In our personal experience, we've had C3G patients with anti-factor H antibodies, and trying to lower those antibodies had no effect on what was going on. And this is something that we still don't understand very clearly. And I know that there's also been a small group that we have published actually together with the group in Paris, in which we described a little subgroup of patients who also did not show much benefit. So in this, in the glomerular family of diseases that have complement dysregulation due to anti-factor H antibodies, it's difficult to say, but I wouldn't advocate for an approach that tries to eradicate the antibodies. I would try to switch off the complement dysregulation, even in these forms, acting on probably mostly proximal complement inhibition when it will be available. The other interesting thing that must be mentioned about these forms is that they are also genetic forms, in the sense that having the anti-factor H antibodies is secondary to the fact that you have a deletion in the genes for the complement factor H regulating proteins 1 to 3. So even this is a genetic condition. So, you don't really switch those off because it's genetic.
Yeah, exactly. Thank you. That's wonderful. I think the amount of useful data that you've given us is enough to listen to this one more time for those who are listening for the first time. I think I'm going to listen to it one more time myself. And the last question is a more personal one. It's a getting to know you type of question. People are apprehensive about it, but it's a nice one. We've gotten nice insight into the human side of the human behind the scientist and doctor, I would say. So the question is, which book, 2 songs, and luxury item would you take to a desert island?
Aha. So I haven't had much time to think about it, but I definitely would say, let's see, a book. I probably would take a sort of, long and comforting book. So I think I would choose something like A Tale of Two Cities by Charles Dickens, a classic. For songs,
Is
even
that a
here,
comforting book?
well, it is. In the end, it has a good ending.
Okay.
Goes through a lot, but it's a beautiful, beautiful book. And in terms of songs, even here, I would probably go for classical if I'm stuck on a island by myself for a long time. So I would say pretty much anything by Mozart or Schubert. I would prefer that to a song, I think. And in terms of a luxury item, I'm not much of a luxury item type. But I think my engagement ring would be something that would give me comfort. It would make me remember the important things in my life. So I think that would be my chosen luxury item if I were on a desert island.
That's so true. That's so true. Professor Teshar from Prague said that he would take his wife
You
as
see, that's a really good answer.
yes,
I
it
don't
was a
think
good
my
answer.
husband would be very happy to be defined as a luxury item, though.
He said that he wouldn't know what to do without her, which I can clearly identify with myself. So,
Yeah.
Marina, thank you very much. This was very illuminating. Thank you very much. And keep up with this great work that you're doing because we need more data for these patients, I'm sure.
Yeah, you're right. Thank you so much for having me. It was a real pleasure.
The pleasure was ours as well. Thank you. Bye bye.
Bye bye.